So let's start now. Welcome to the Indonesia Project Global Web Seminar on Coronavirus Outbreak. In this 7th episode, we will be discussing the risk for coronavirus vaccines and drugs and the complexities in Indonesia. We have invited Dr. Ines Atmosukarto from John Curtin School of Medical Research, ANU, and also the CEO of Lipotek, a biotech company based in Canberra. She will talk about policies on vaccines and drugs in Indonesia, focusing on those relevant for the handling of COVID-19. Then, to discuss the demand side of the drugs, we'll have Anindita Gabriella Sudewo, or Gabby, a PhD scholar at UNSW, and Aditya Wardhana, or Edo, from Indonesia AIDS Coalition. They will be drawing a comparison to the experience faced by people living with HIV in Indonesia. As usual, your hosts are myself, Arianto Patunru, along with Nurkomala Mulyani and Baskara Adiwena from the Indonesia Project. This webinar is supported by Australian National University and Australian Department of Foreign Affairs and Trade. We will have Q&A session at the end of the presentations. You can ask your questions by typing them on the Q&A box or by raising your virtual hand. So let me now go directly to Mbak Ines to have her presentation. Over to you, Mbak Ines.
Thank you. Trying to share the screen. Can you see the screen?
Yes.
Okay, great. So thank you very much for the opportunity to have a chat with everyone through this media. So although I know that the title included policy, I mean, I'm really not an expert in that field. What I've tried to do through my presentation is more to give an overview of the complexities associated with the disease, the testing, the development of vaccines, and the identification of new drugs to hopefully put everyone on a similar level playing field when it comes to this very complex topic, because for us to be able to understand the complexities of developing new vaccines and new drugs, then I think it's very important that we understand the background in the disease, and that's why I think that the crossing between different fields is very important. So I'll start with the disclaimer. I'm not a virologist and I'm also not an epidemiologist. The views are my own. And my background is really in molecular and cellular biology and vaccinology. And as you mentioned, I spent most of my time with a niche biotech startup that actually focuses on the development of new vaccines. And we have a long-lasting relationship with Biopharma, which has given me an interesting insights in the complexity of developing new vaccines in Indonesia. So just with my presentation, I think this is probably the most biology that this forum will ever have. I'll start with a snapshot of the disease, and I'd like to highlight that it's actually quite interesting to see how something that's 120 nanometers in size, so that's like a nanometer being a billionth of a meter, has caused so much havoc in the world. The second part of the talk is really, you can't escape the biology, because I think I would like everyone to have at least a good understanding of the disease and the difficulty in actually treating and developing vaccines for this disease. And I'll try and touch on 3 specific points: the testing, the vaccines, and the drug development, and try and frame that with what's happening in Indonesia by highlighting some of the news that have come out of Indonesia. A lot of these news I'm getting through some of these WhatsApp group that I'm sure everybody also gets the news, a lot of the news that ways, including through groups that include a forum of young scientists. It's funny because young is quite subjective, but some of my colleagues in Indonesia have formed this Young Scientists Forum, which at the beginning of the disease was very concerned with how slow the testing was in Indonesia. So if we look at how COVID-19 has taken over the world, since January, for me, really, it's really interesting to look at in really through the eyes of the media. I personally first was aware of the disease through Twitter, through some of the posts posted by Helen Branswell and Stephen McDonald, who identified that the new cases of pneumonia of unknown causes had happened, were occurring in China, and that was in early January. But I think by then everyone was still going about the merry world. Well, I was on holiday then, and it's not only until the middle of January when cases started to emerge outside of China that I started to pay a lot more attention. First cases out being in Thailand, and the first deaths being in the Philippines. Personally, I think I started to get very worried when news of China building a couple of temporary hospitals was starting to emerge, because in my head as a scientist, you wouldn't put that much investment unless you knew that there was a significant problem. And as the scientists in China started to identify the virus and what type of virus it became, and when it became obvious that it was a coronavirus, which was very closely related to SARS, I think I started to get quite worried, and probably started to warn family and friends. And I think, this virus has now really grabbed all the headlines, especially when leaders of the world start to come down with it. So if we go next and look at the timeline of the disease, it's again, you can say that although it started in the late December in China, I think in Indonesia, we'd only started to see our first case in March, and that space between, or that time between China, oh, it's gone. Sorry, that time between the beginning of is my presentation showing or?
Yes, it is showing.
It is showing, okay. The time between when the cases started to appear outside of China and when the first were detected in Indonesia started for me to identify that we might have had an issue in
share it again. Yeah,
it's gone. I'm sorry.
Yeah.
Okay.
Good.
Now, it started to be problems with testing in Indonesia, especially as there were news coming out of the USA that there were issues with the kits, the testing kits that produced by the CDC there. And as we can see, the timelines have been different for the disease, have been different in different countries, which really reflects local conditions in those countries. Now, I think to be able to really to think critically about the disease and the responses to this disease, it's actually important to really understand, and in this case, understand your enemy, the virus. And the reason for that is because understanding the virus and the spectrum of the illness will allow governments to actually make better decisions as to how to make decisions relating to capacity to really answer this huge challenge. And that includes, trying to understand what are our options when it comes to therapies, how to identify, how to triage patients, and that all will come down to the planning for the response to this huge challenge. And as I will touch on later, when it comes to the testing, things like the procurement of supplies is something that has been a huge challenge for all the countries that are trying to face this virus. So this is your first biology slide. Why all the fuss and about this virus, and why is it causing so much problems? And it really comes down to trying to understand how our immune system responds to a respiratory virus. And in this case, I'll use what we know about another big problem, which is avian influenza. And in fact, it is how our body responds to a virus that infects our respiratory tract that really will determine the cause of a disease. So when we're first faced by a virus, our innate immune response will identify that we have been exposed to a pathogen, and then it will start a response to try and get rid. And this response is non-specific. It basically tries to eat up the virus and to eliminate it from our body. If the innate immune system is not able to eradicate this pathogen, then it will start to mount an adaptive response. And in this case, the adaptive response is where the body starts to try and produce, weapons against your virus. And in this case, the weapons are in the form of antibodies, right? And if your body has actually produced enough antibodies, it will be able to neutralize the virus. And if you were to come in contact with the pathogen again, then it should actually protect you from it. So that's the whole basis for protection once you have been infected. However, if your body is unable to clear it by either the innate response or the adaptive response, what you get is this production of inflammatory cytokines, and these are molecules that are produced by your immune system, which try to fight the infection, but are not able to. And this is when you have a high production of this sort of cytokines that you get the what you call a cytokine storm, and you will probably have heard it in the media. And in fact, it is the cytokine storms and this inflammatory response that causes the severe disease. So in fact, it's not the virus per se that's causing the severe symptoms, but it is the response from your immune system that does. Now, what's the virus? So this virus is actually, as I said, very small. In fact, it can be considered as not being alive. It's a very small organism that only contains RNA. It's actually not able to replicate by itself. It needs to infect you, or infect a host, to actually be able to multiply itself. And that's why the ability to block that infection is how you are going to get rid of this virus. Now, the disease has all sorts of symptoms, and I've highlighted some of them in this slide. You have some that are very mild, and while some others are going to be a lot more severe. The majority of people only experience very mild symptoms, and some of them are quite peculiar, including, for example, the loss of smell. So that's probably one of the first questions I would ask someone who's developing these sort of symptoms. Now, if we look at the severity of the disease, pre-existing medical conditions have been reported to have to be factors that will increase the severity of the disease and increase the risk of death. And some of these are cardiovascular, diabetes, chronic diseases, especially chronic respiratory diseases, and cancer. But more recently, we have also observed that not only do we observe respiratory issues in people that are affected with the virus, but they develop also more severe symptoms that are more systemic. So sepsis-like symptoms which affect your entire body, including blood clotting problems, have now been reported and are probably at the basis of the severity and the mortality, especially in the high in the groups where most mortality have been since, which is the elderly population. We have learned a lot from a number of these scenarios, especially the scenarios where infections have occurred in some of these cruises, and it is from this sort of initial informations that we've started to understand the transmissibility of the disease. And whilst the disease is not as fatal as its cousin, SARS, where SARS seemed to kill almost 10% of the people that were infected, or in fact even MERS, the fact that it has a much lower fatality rate means that the virus is able to remain in the population for a lot longer. So how do we deal with a problem like the coronavirus? There's really only three ways. You have to test, which is what most countries are trying to do at the moment. And at the moment, we are still unable to treat or prevent because we are still trying to find what are the best treatment and the prevention for these in the form of vaccines. So at the moment, testing remains our best weapon against the virus, and the testing is really to enable us to identify and isolate the people that are infected. So when it comes to testing, there's actually two types of testing, and I'm going to spend a bit of time on the testing issue, because especially in Indonesia, there's been a lot of reports about the different types of tests and whether or not we have enough capacity. There's two types of tests that have been talked about mostly in the Indonesian media. The nucleic acid or PCR test, which actually looks for the virus, and the antibody test, which actually detects the response. So if you remember one of my earlier slides where I was talking about how immune responses are generated, these rapid tests or on-the-spot tests actually look for the antibodies, not for the virus. So if you come back positive for a rapid test, it suggests that you have been infected at some point. Whether or not you remain infectious is not clear at this stage. The only test that will be able to confirm that someone is actually infectious at the time when they were tested is the PCR-based test, which actually looks for the virus itself. But these tests are actually quite technically challenging. They require specific reagents, they require skilled operators, and they require access to specific instruments. And in fact, each instrument comes with a very specific reagent set, which means that some of the bottlenecks that we are seeing are due to not only the ability to access the instruments, but also the ability to access the reagents that are required to actually conduct the testing. Now, again, why I want to spend a little bit of time on the test is because the two different tests, as I was trying to explain earlier, actually tell you two different things. If you were to have been exposed to the virus, say here, where week or time 0 is the time when you start to display symptoms, you are likely to have been exposed to the virus actually 2 weeks prior to your first symptoms. Now, if we look at what tests can do in this period prior to you developing the symptoms, it is only the PCR-based tests, and these are the ones in blue and pink that are actually going to be able to detect and demonstrate that you are infectious. If you look at where the antibody tests are able to actually detect a positive signal, it will be much later, as seen by those graphs that are in the dotted lines. So a positive antibody test that comes using some of these rapid tests actually are, in my opinion, a bit too late, and using this sort of tests are actually not very useful when it comes to trying to detect positive cases in the populations. And I think I've probably risked being a little bit complacent or overly positive when using this sort of rapid tests if they come negative. A negative test from a rapid test really doesn't tell you whether or not you have the virus. It will only tell you whether you have mounted a response. So for me, challenge number 1 in Indonesia is the testing. When it comes to the PCR-based test, we started with only one laboratory being allowed to do the testing, and that was the laboratory of Litbangkes in Jakarta. But we are now have increased our capacity dramatically. In fact, I think there's now almost 60 tests spread all over Indonesia that are able or have the capacity to do the tests. And this is very important because, again, as I said, these PCR tests are very technical, and even the transport of a sample from, say, somewhere in Sulawesi to Jakarta risks resulting in a false negative if the samples are not transported properly. So I hope that from this we realize that not all tests are created equal, and that the RT-PCR tests are really the gold standard for these for detecting the virus. The issue is that in Indonesia at the moment, the time that it takes to actually get the results from these tests are quite long, and while you can get the result of your test in less than 24 hours in Australia, it takes days for the test results to actually be announced in Indonesia, and that creates a problem because we're actually not really getting the real picture of the dynamic of the disease in Indonesia because of that. So for me, it remains a question as to why these rapid tests remain so popular in Indonesia. There's now a lot of places that offer paket swalayan where you can actually go and get your rapid tests, because I actually don't really see the point in doing these tests. These are and some of these challenges with the tests are actually quite numerous. We know that the reagents are an issue, but not only that, some of these rapid tests have also been shown to actually not be very accurate. And in fact, I think 30% accuracy is some of the reports that I've seen for some of these rapid tests. So again, not only are we wasting time and resources on these rapid tests, they're actually not very useful. Indonesia is trying to develop some of its own tests, and we've seen that some companies and BUMN have taken leadership in developing the kits that are necessary to conduct the PCR test. But unfortunately as well, we see these also being involved in the development of some of these rapid tests. Again, I don't want to say that these don't have a use. They are very useful in trying to understand and get a very big picture or broad picture of what has happened in a place, how many people have been infected, but they're not really useful in trying to determine, are you infected at the time? the logistics of importing these the reagents for the kits are tremendous, and even though Biopharma is boasting producing 50,000 kits, we have to realize that all of the ingredients that go into making these kits are actually imported, and the kits are just assembled in Indonesia. So that still remains quite a big issue. If we look at how well we've done when it comes to testing, we can see that in Asia, we have one of the lowest testing rates in Asia, lower even than Bangladesh, for example. So that remains a very big challenge for Indonesia.
7 minutes, Mbak Ines.
Okay, so I will continue with the vaccines. Why are vaccines important? As I said, vaccines are important because they help you develop products that can induce protections. And the form of the vaccines are very different. You can actually either use a part of the virus. So, for example, you take one of these proteins that are presented on the surface of the virus, and you formulate it so that it actually stimulates your immune response. There's actually a number of these different viruses in development at the moment, and the development of a vaccine normally takes years. In fact, I've been working on a vaccine for more than 10 years, but we are hoping that because of all the money that's been put into developing vaccines worldwide, I think the best estimates are 12 to 18 months. We have to realize that developing a vaccine is actually a very long process that requires testing in numerous phases. At the moment, there's hundreds of these candidate vaccines in development, and I think it will be interesting to see when the vaccines will be available, but also how are we going to scale up, or how is the world going to scale up the production of these very specific products. In Indonesia, there's really two parties that are taking part in the vaccine development locally, and that's again PT Biopharma and also the Eichmann Institute. But I think both places, I think the challenge will be to actually find sufficient funding to do these developments. Now, vaccine is important because it enables you to induce herd immunity. That is, the more people you have protected in a population, then the more you are able to protect the more vulnerable people in that population. And herd immunity can only occur if you have a vaccine. Quickly, the third challenge that we have is finding a treatment, and the treatment will really be depending on which phases of the disease you're trying to target. And I think it is important to highlight that because the disease is actually causing inflammatory response, it's actually a sign that your immune system is in overdrive. So you can either try and target early to stop the vaccine, the virus infecting a person, or you can target the later stage, which is to try and stop your immune system from overreacting. And that's a very challenging thing to do. At the moment, there's a number of drugs that have been tested, and one of the challenges is that doctors are learning on the fly, and that because the disease has only been known for the last 5 months, and therefore the testing actually has to almost happen real time. And we are not able to conduct clinical trials the way that you would normally do it. One of the treatment that has been boasted initially was this malaria, very old malaria drug, but more and more, I think it seems that this compound is really not the golden bullet that has been promised. Gilead, which is a US-based biotech company, seems to have repurposed one of its Ebola antiviral drugs, but even then, this drug is only able to shorten the disease from 14 to 11 days. Now, in Indonesia, I think very quickly. Treatment is a bit different, and we see the media now being flooded by all sorts of news about all sorts of different treatment. And I think that's another issue that's very specific to Indonesia, where I think the population is now being confused by all these reports in the media. And communication is a very big challenge when it comes to tackling the disease, because I think being flooded by all sorts of different type of messaging, you know, imunitas ini kata kunci melawan pandemi. Well, you can't get immunity unless you are either vaccinated or you are or you have been infected. So I mean, this sort of news is really not useful. Other communication issues, and I think I'll just highlight this one. On the same day where Indonesia was reporting one of its highest numbers, I think the government was also reporting that the tambahan kasus corona relatif rendah, so that we are now having a relatively low increase in cases. So the messaging is very confusing. Indonesia is thinking ahead, however, and what we can see that is that they're already starting raising some of these important issues. If drugs become available and if vaccines are developed, and they won't be developed in Indonesia, who's going to get access, and how is the world going to ensure equitable access to these? So I'll just finish by recapping. Vaccines won't be available for a while. I think if we see a vaccine in the next 12 months, that's going to be a success. But who's going to get it? How much is it going to cost? At the moment, we still have no proven treatment except for remdesivir. But even then, I think the benefits are minor. Testing, tracing, and isolation is still our best weapon. And I think the response remains hampered by the lack of scientific leadership. There is no clear spokesperson when it comes to science or the scientific aspect of the disease. Bureaucracy, which has, I think, hampered the initial response, but also the procurement of all the material necessary for the testing, misinformation, and again, the fact that Indonesia has such a unique geography makes everything more difficult. Thank you for your attention.
Thank you so much, Mbak Ines. That's very thorough and informative. So let's now turn to the second presentation. So over to Gabby.
Thanks, Bacho. Let me just share this screen. Let me just see if I can. Okay. Can everybody see that? Yeah.
Can you go full screen?
Yes. Hang on. Sorry.
Good.
Okay. Thank you. So thanks very much, Ines, for the background, because actually some of the takeaway messages are what's going to be the basis for my and Mas Edo's presentation. So we're going to be reflecting on experiences from people living with HIV in Indonesia in the context of the COVID-19 pandemic. So I'd like to, I guess this isn't the disclaimer, but just to point out that I am a spokesperson for a group of people who worked on a very rapid survey about less than 2 weeks ago in collaboration with the Indonesia AIDS Coalition. And I'll be presenting a little bit about the survey and its implications and what we think should be a priority for the health system given the current pandemic of COVID-19. So the outline of my presentation will be about the urgent need for a rapid survey to assess needs and changes in services for people living with HIV in Indonesia during the pandemic. The initial information from China has said that people living with HIV but are virally suppressed are still, they have approximately the same risk as any other person in terms of dealing with COVID-19, but it's also important that people living with HIV then get steady access to treatment, antiretroviral treatment, as we know that HIV is currently considered a chronic condition that can be managed with antiretroviral treatment. So I'll present a preliminary result of the survey. We just finished it less than 2 weeks ago, so we're still processing the data. We did a quick cleanup and very basic descriptive statistics, but we've learned quite a bit from it. Highlight of changes documented since March 2020, which is when the Indonesian government declared a state of emergency for the COVID-19 pandemic. And moving forward, what needs to be considered for the COVID-19 pandemic responses in the context of groups with chronic diseases. So why this survey? Since March 2020, different regions in Indonesia, like Ines has pointed out, it's about testing, treating, and then preventing. But because there is no effective treatment yet, and there's no, we have to admit, there's no, testing available for everyone yet. It's all down to prevention, and so social distancing policies have been implemented. And one of the consistent pandemic responses so far focused on the stay-at-home message. We're seeing that there's approximately 127,000 people living with HIV who are currently on treatment as of December 2019. And within normal, as in outside the pandemic, people living with HIV who are on treatment would need to come to health services to access their medication, usually monthly. But there's some variation in that as well. But in the past few months, there have been some antiretroviral stockouts reported in several regions in Indonesia. And so we saw that there was a need to map current situations regarding treatment during the pandemic and the changes in living circumstances so far. So this online survey, this was a survey online aimed to map changes and to assess the needs of people living with HIV on treatment. The period was just very quick, 23 to just 1 week. This was not really random sampling. We collaborated with the Indonesia AIDS Coalition, and we recruited respondents through their network in 22 districts across Indonesia. Out of 775 responses, we managed to clean up the data, and 661 responses were available for analysis. So just a brief about who they are. I'm sorry, this is a bit. So we see that most are men who responded. Most of the people who was in the survey came from Java, so that would be a bias as well. We see that there's actually 46% working in the formal sector, as in having an employer, 16% in the informal sector, 15.3% saying they have their own business, but almost 22% have said that they're not working. And we can see that from the people who have responded, about 79% make less than 4 million a month, which is the minimum basic income in Jakarta, I think. So that's why we put in 4 million as one of the standards. In terms of ownership of national ID and national health insurance, so KTP and BPJS, 99.7% have a national ID, and almost 81% have an active national health insurance. We can see that almost 40% are government subsidized, so penerima bantuan dari pemerintah. Almost 31% was independent, 7.4% didn't answer, and almost 22% said that their health insurance was covered by their employer. So in terms of accessing antiretroviral treatment, we need to notice that 93% of them are dependent on antiretroviral treatment that is free and provided by the Indonesian government. And so they're very dependent on how the Indonesian government provides treatment. We're seeing more in public hospitals and puskesmas, again, government-based healthcare centers. In terms of changes in access to antiretroviral treatment post-March 2020, again, I need to emphasize that this is only less than 2 months after PSBB or social distancing policies were implemented. 73% said that there was no change. 8%, about 8.3% said that they've received less treatment than usual, less pills. 16% says they've received more pills, and 3% said no, didn't give an answer. What was also interesting is the changes in health facilities. You could see that almost 50% said that there were changes in how they were accessing treatment. So decreased opening hours in their health facilities, decreased days of the week, being referred to other health facilities, and having a lot of support from community workers or NGO workers being able to pick up their treatment for them. We've had some qualitative answers as well from open questions. And this is where it gets interesting, because there are, again, the whole idea of the survey is to document changes. So please don't focus too much on the numbers as of now, but focus on what's been happening and what the changes have been. We've recorded people having to return to their hometowns due to a lack of treatment in their current cities and complexities around changing clinics. So issues around mobility of people living with HIV, who, without treatment may be immunocompromised and may be more susceptible to severe effects of COVID-19. People have reported having to pay and no longer able to use BPJS or the National Health Insurance to access treatment. There's been a lot of operational changes in the clinics, including longer queues and less consultation time with the doctors. But we've also documented some good practices, whereas there's flexibilities around antiretroviral provision, including usage of courier services or buddies, and some flexibilities around the number of pills that they receive. We asked a little bit, this is just a snapshot of our data, by the way. There's still more to come, but given it's only been less than a week since we were able to start cleaning the data, it's still pretty much in its preliminary stages. 79% mentioned that they needed sembako, which is interesting considering that a lot of the people in these groups are supposedly eligible for government support in terms of the social security support, but they're still saying that they need sembako or basic food products. It was interesting to note that for the others, people were talking that they need access to national health insurance, they need internet, they need jobs, and suspension of credit. There's also 12% who talked about the need for protective gear, such as masks or hand sanitizers, and some requested cash. In terms of urgent needs, this is what people have been saying. They're afraid of depleting stocks of antiretroviral treatment and need to be reassured that it will always be available, considering that their health is fully dependent on being able to access antiretroviral treatment. There are anxieties around the need to stay at home and need to access health facilities for HIV care. And related to that, anxiety around the need to observe social distancing policies and need to earn money. This becomes very, key, because without proper testing available, as shown with Ines's presentation, without effective treatment available, the only thing that's left to do is to socially distance, they say. But there's also the very urgent need to earn money. There's some more data that talks about that, but we haven't been able to present here around time spent outside, being able to access clean water and soap, but yeah. So there's also a worry about decreasing or loss of income as a result of COVID-19. So we're seeing that in very vulnerable groups, it's not as easy as socially distancing, and that it will help. This is also interesting because one of the points that Ines talked about was the idea around information. We noted that those who are perceived to be reliable sources of information are about 25% says they only trust government spokespersons, and 17.5% trust health workers alone. And remaining trust information from a combination of sources, including NGOs, community leaders, family, and friends. And mediums of information that they perceive to be reliable are the TV, official government websites, social media, WhatsApp group, and used in combination. It's just interesting that even from our data, it shows that there's a need for official government information that is trustworthy. Okay, so I guess reflections, COVID-19 responses and some unintended consequences. Again, the results need to be taken as coming from a rapid survey aimed to capture changes. So current numbers shouldn't be considered representative. And there's a lot of biases. Only people who have national IDs and access to cell phone and internet could complete the survey because it's an online survey. Again, this pandemic has changed the face of social research everywhere. One of the things that we wanted to point out was that 8.3% reporting changes in number of ART and about 50% reported changes in HIV care. So we are still analyzing further to see who they are, where they live, and if it's linked to access to antiretroviral under normal circumstances, since it's already well known that places outside of Jakarta and outside of Java have experienced uneven distribution of antiretroviral even before the pandemic. We saw that 80% reported decreased income since March 2020, and could be more if we count those who relied on partners or parents' income. So this just adds to the vulnerability of groups that need to be put into consideration. And so COVID-19, one of our takeaways from the preliminary data is that it highlights the complex realities around the social security network, around data and eligibility criteria, which still excludes some groups, such as people living with HIV, especially those without permanent housing and dependent on the informal sector as a source of income. So, we see that there is also always an issue about how the data is mobilized or utilized, organized, the eligibility criteria, whether certain groups like people living with HIV or other groups who are more vulnerable are represented. Moving forward, the idea is that Indonesia's health system needs to anticipate these health inequalities in vulnerable populations and be more oriented towards health equity. And, health interventions, we see the need for it very much based on what all the data that Ines has provided about COVID-19, but any health intervention must address the structural barriers and take note of structural enablers that promote changes at the individual level practices in Indonesia. So if we talk about socially distancing or physically distancing, or if we talk about wash your hands, use a mask, is this something that can be done by everyone? All these structural barriers and structural enablers need to be taken into account. It's not as easy as telling people to wash their hands or stay at home. One of the takeaways was that stay-at-home message ignores the fact that some Indonesians not only are dependent on daily wages, but also that some have specific health conditions such as HIV, which requires them to access health services. The fear of having to access health service, going out of their homes, while there's this constant message to stay at home as a way to prevent infections of COVID-19, because there is no test or treatment that's readily available for everyone, it makes people from particular vulnerable groups even more vulnerable. So this is what we thought, what a health equity-oriented health system may look like, reflecting on the data that we have. We see that there are flexibilities around provision of antiretroviral treatment during COVID-19, like more pills to use, use of corridor surveys, and these can be considered as practices to be implemented long-term, so post-COVID-19. And these changes highlight the possibility of HIV or other care beyond clinics, including community-based service models. And so we can engage resources beyond government-based structures. I think our message here is about wanting a more, a socio-ecological approach to health beyond the biomedical. We see that the biomedical approach is very important, trying to find effective tests, effective vaccine, effective treatments. But one of the biggest obstacles in being able to implement these, should they be found within the next year or year and a half, the social context of how these interventions may be implemented would need to be taken into account. And we're talking about, risks and vulnerabilities that are so layered within the Indonesian society. And I guess that's how we would want to advocate for more of a socio-ecological approach. I'm sure Mas Edo after me will have more, ideas around how this may look, especially reflecting on his experiences advocating for the rights of people living with HIV in Indonesia. So thank you.
Thank you, Gaby. So let's go straight to Edo.
Okay, thank you, Gaby, for the presentation. Just want to make some additional reflection from the survey. Actually, my organization, Indonesia AIDS Coalition, is part of the SRHR.
Sorry, Gaby, can you stop the screen share?
Sorry.
Okay, go ahead, Edo.
Yes, my organization, Indonesia AIDS Coalition, is part of the SRHR, a national crisis response team. So usually we respond to the natural disaster situation, but at this moment we need to also responding to this pandemic situation. And our organization is also working closely with the Office of the President. Just recently, we try to solve the issue related to the ARV stock disruption that happened in Indonesia recently. Just giving a situation in the field, the COVID-19 impact the most socioeconomic aspect. For instance, the treatment interruption, decrease of income, loss of job, and that is some of the data that we receive from 23 districts where we have a monitoring network. And we also see that vulnerable patient group sometimes is overlooked. For instance, like HIV patient. And then the latest data that published by the MOH related to the program evaluation summary for the Q1, social restriction is affected, suspend outreach activity and program implementation. So if we look at this report, actually our output for the most of the activity is quite low. So there is the situation that now it happened in Indonesia. And to add the thing that already mentioned by Mbak Ines and Mbak Gaby, the first thing that we want to highlight is related to the health promotion messages, because the government spokesperson on COVID-19 is provide an update every day on the situation. Based on the survey, we also know that the message from the government is really believed by the people living with HIV in Indonesia. And they're only using a single key message, stay at home. And based on our observation, this single key message are not accommodating other illness group. For instance, like HIV patient that need regularly come to health services and to obtain to get the ARV medicine. And sometimes the campaign on HIV protocol, we know that the Ministry of Health already issuing the HIV protocol, but it's only just a short letter, and they never make a campaign to ensure that this message is well received by the people living with HIV. And from our monitoring network, we also get the information that many people living with HIV and CAP is still have a lack of knowledge about this COVID-19 itself, including how it's transmitted and how to prevent the COVID transmission. So the other thing that we want to highlight from the survey actually, it's related to the underrepresentation of people living with HIV and CAP in government social security system. We know that our government is already allocating the 110 trillion IDR to become a social support from the government that can cover around 20 million beneficiary family. And the data, it's been taken by the Ministry of Social Affairs. But again, related to the people living with HIV, sometimes the mistargeted social support are being reported by our friends. Because sometimes eligible family are not getting support, while ineligible family, the people from the middle income family, they receive the support. And we also face the issue related data from the Ministry of Social Affairs itself, and how to determining family eligible on social support due to social stigmatization. Because, for instance, like people living with HIV, for sometimes like people from the sex worker, from the LGBT, they need to live outside their identity card domicile. So it's sometimes create a challenge for them to be accommodated on the government social security system. And we also noticed that there is an increase in marginalization due to sexual orientation, and we also see the increase of the domestic violence during this PSBB situation. And related to the HIV service during COVID-19 pandemic, access to health service are limited. Some of the health service provider is reducing their operational hour, and some voluntary testing services is closing at this moment. And again, referring to my first comment related to the communication issue, sometimes the people living with HIV is reluctant to visit health service because they are afraid for their vulnerability to be infected by the COVID. And now we also see, actually we already several times mentioned to the government, this vertical HIV service sometimes is incompatible with the JKN national health system. Because, for instance, people living with HIV need to get their ARV every month, and they need to come to the hospital. While when we using the JKN or national health system, national health insurance, they're using the referral system. So it is sometimes is not met with the people living with HIV need, because it will also increase their it will increase also the vulnerability related to HIV if they need to come to puskesmas and then after that go to the hospital. And actually, the last point related to the HIV service during COVID pandemic that become our concern is related to supply chain disruption. Due to the lockdown and closed border affect ARV supply. Just recently, we work closely with the President Office. We try to solve this issue. On last week, we invite 2 of the state pharmaceutical company and asking for their commitment to fulfill the country need for the next 80 months of the ARV. Because we know that some of the country is under a lockdown. For instance, like China, like India, and it's create challenges for us to get those ARV, because most of the ARV consumed by people living in HIV in Indonesia is the imported one. The dependency to this imported product is also now become a huge concern from our government in Indonesia, because now during this COVID pandemic, we start to realizing that this dependency is very dangerous for our national program. And ARV access for transportation on periodic migration, because at this moment we also have the Lebaran, yeah, in Indonesia. We know that during the Lebaran, many people usually have a tradition of mudik or homecoming to their home. So, and this is also a situation that create a challenges for people living with HIV to get the ARV access, because once they registered in the origin health services, and then they need to go or migrate to another city, it is not so easy for them to get the ARV on those the nearest health services. And it's also create challenges because now in Jakarta, we know that the unemployment is getting high. So many of our people living with HIV need to go back to their home city at this moment. We want to highlight some effort from the community during this COVID pandemic.
5 minutes,
some of the community doing a campaign for HIV safety protocol. We also collaborated social support scheme. We also advocating, like Gaby mentioned, for the differentiated care related to ART mechanism flexibility, including the multi-month dispensing. And we also increase collaboration with NGO to set up health service outside the health center. We're using the virtual outreach, viral load test drive-through, ARV transporter, and other means. And socio-economic and human rights impact survey on the COVID-19 impact also run by our community to measure the impact of this COVID-19 to the community. And the last, what we are doing during this COVID is we strengthen our monitoring and reporting related to ARV availability, because we found out that in some area, the ARV already run out, and the people living with HIV already given only 5-day, 10-day supply, or even some of the people living with HIV only receiving just one of regimen or monotherapy, which very dangerous to their life. So this is the further need. This is my last slide actually. In the next future, we want to make an advocacy for better and friendlier data collection mechanism toward people living with HIV and CAP, because we don't want that these people living with HIV and CAP is become outside from this national or state social support. We also try, because we know that the message come from government is the most reliable and trusted source to the people living with HIV. We want to ensure the government to include HIV safety protocol in COVID-19 mass campaign. And we, together with Mbak Gaby team, we also want to make another survey, continuous survey on the people living with HIV and CAP knowledge about COVID and how we can better address and deliver the prevention message to them. And the list is, this is our advocacy plan, how to improve the HIV integrated JKM system. So that is from me. Thank you.
Thank you very much, Edo. Let's now go to question and answer session. I can see that Mbak Ines is ready to answer Rose's question. So just go straight to you, Mbak Ines.
Okay, Faros, that's a very, very good question about whether if you get infected, you will get immunity from infection. In fact, we know that that happens with a number of diseases. For example, if you had the measles, then you will be protected from getting the measles again. The problem, I think, with COVID-19 is that we actually don't know for sure that a prior infection will protect you, because there's been reports of people that have been sick, recovered, and then come back to be positive. So that's one. We also don't know what the long-term impacts of the disease will be, and I think Faros was kind of like alluding to the herd immunity from people just get infected. The thing is that we don't know the long-term impacts of the disease. Even if you didn't suffer the severity, the severe symptoms when you were infected, we don't know what impact that will have on someone who's had the disease long-term. So there's really some long-term health impacts that we need to consider. And the other thing about, and that's Ros's second question about trying to, I guess, let the infection run its course, is that...
sorry, Mbak Ines, maybe for the attendants, we can repeat the question so they know what question Ros asked.
I'm trying to find
about the developing immunity by getting the disease.
Yeah, so that was the first question. And then I think Faros then went on, if no vaccine are available for a long time, and if we become immune and when we get the vaccine, then isn't that the way to go, to just let people get infected, right? And the problem with the idea of trying to let people get infected is that to let people get infected, we still need to be able to deal with the people that are going to develop the severe symptoms, right? So the health system needs to be ready to deal with those patients if you wanted to let the disease run through the population. So trying to build up the health system to allow that is a huge problem. And at the same time, we still also need to be able to provide the care for all the other patients that need care. So I think trying to let this infection run its course is really not going to be possible, especially in a healthcare system that has limitations. So I think a vaccine really is, and it's not because I work on developing vaccines, but we know that vaccines are the best healthcare interventions. So I think that still will be our best bet. Hope that answers Faros.
Thank you, Mbak Ines. While you're having the microphone, can we answer a question from Firman about the distribution chain of vaccine in Indonesia and also the procurement system? Can you say a word about that?
So, Pak Firman, the distribution of any vaccine, be it in Indonesia or anywhere, is always an issue. And that's because vaccines generally need to be refrigerated. So vaccines, because they're made from parts or bits of the viruses, are very sensitive to temperature. So a big problem with the distribution of the vaccines is maintaining the cold chain. But I think in Indonesia, because of the network that's already there, that Bio Farma uses to distribute the vaccines that are already on our immunization program, I think that part is not as much of an issue. And how severe is the prevalence of substandard fake medicine in Indonesia? That's an interesting question. I don't know that I have seen I have seen a formal study, but I would say that we all have to be very careful. And I think especially in times like this, where there is such a need to find tests and to find drugs or treatments, I think this is actually a very vulnerable time when it comes to substandard products, and we've seen that Tempo article that showed that some of these tests that were procured from the Netherlands were actually produced in China, and then actually quite inefficacious. Yeah, I think that hopefully that answers for Firman.
Yeah, thank you, Mbak Ines. For the next one, maybe Gaby and Edo can give some information. This is a question from Lila. How do you see the impact of local politics in the procurement and distribution of test packs? unintended drugs and essential drugs. Yes. And what makes some regions can test while some others cannot? Gaby?
I think maybe Edo would have a more definite answer, but in terms of procurement of essential drugs and medical supplies, the issue is with geography. It's with because at least learning from the HIV experience, procurement for HIV-related medications or testing, it all depends on how much the local government considers it as a priority, because each health, the Dinas Kesehatan or the health office from each province will have their own authority to decide what would be the priority or how they would prioritize their health budget. And so in the case with HIV, at least, that becomes an issue because there's also a lot of stigma associated with HIV. Seeing that there's starting to be some stigma associated with COVID-19 as well, this might become an issue. It depends on how each government, at least my answer would be that each local government then has the authority to decide how much they're willing to spend and how they're going to spend their health budget in that particular area. And so, you know, referring or reflecting on part of Ines's presentation around, you know, all these cures for COVID. You know, if a local government then decides they need to, you know, prioritize that over others, then that could be a problem in terms of addressing other health problems. I know COVID-19 is an issue, but it doesn't mean that other health issues stop when COVID-19 is an issue. We also need to think about those things
Sure.
as well.
Thank you. Before we turn to Edo, can you also answer a question from Philip Eldridge, Gaby? It's about the cooperation between Puskesmas, NGOs, and civil society groups at local level.
Yes, this is still encouraged, but also in terms, again, reflecting with HIV, the role of civil society has been major in encouraging people to be tested and treated. But for the past few years, it has been more government orientated in terms that health-oriented NGOs and civil society groups are only then told to refer people to healthcare providers that must be based at government-based facilities, which is clearly shown in the results of the survey that more than 70% were accessing, more than 60% were accessing treatment at government-based facilities. In terms of advising government authorities of access difficulties by many groups, this is where organizations like the Indonesia AIDS Coalition play a huge role in being able to advocate for the rights of particularly vulnerable groups who need basic, you know, to meet their basic rights to health, basically. So I think that would be my question. And also, you know, in trying to engage more, sorry, just one more, it's a little bit frustrating that the ministry or basically the health system has not really used these resources as well, which is why in our presentation we talked about the possibility of engaging resources outside the government-based resources, as it seems that in this particular situation, these are the resources that we can turn to, ideas around social community systems or kinships that can help provide services to people in need.
Thank you, Gaby. Edo, do you want to add something to that?
So basically, to respond that why there is a differentiated on the testing. Actually, like Ines already mentioned that in Indonesia, we're using two methods of of testing. The first one is we're using the RDT, the rapid diagnostic testing. The second one, and to be the confirmation test, is we're using the PCR. Yeah. For the rapid RDT, actually, we don't have any issue because it can be spread quickly between from Jakarta to another district. But again, based on my understanding, even the WHO still not have any pre-qualified the RDT. So the only test that they suggest is the PCR thing. So related to the PCR test, we have several issues actually in Indonesia. The first one is not all of the provinces in Indonesia have the BCL2 laboratory. So, and based on our regulation, perhaps this is, I'm not really sure whether this is only our regulation or it's global regulation. The PCR for the COVID need to be established on the BCL2 laboratory. So sometimes if the province, one province, they don't have the BCL2 laboratory, they send the specimen to another province that can run the test for the PCR. And the second issue related to the transportation, because now many of the local flight, local courier flight is stopping their operation. So it is really difficult for one province to transporting the specimen to the another province that have the PCR district. Even though we are at this moment is hearing that the government working closely with the Global Fund Supporter Program, now we are trying to mobilizing and utilizing the gene expert. But again, it is still need to be performed with the specific requirement of the laboratory. Even though we do have gene expert machine across Indonesia, but not some of them is being placed in the BSL2 laboratory. So at this moment, the government in Indonesia is still also trying to looking away how to utilizing this gene expert, because it can be extending the PCR test to the other province that don't have the PCR machine, not the mobile, not the mobile one, but it's still under process at this moment. Yes, I guess that's from my side.
Thank you so much, Edo. I think it's been very useful discussion, and I believe all the questions have been answered verbally or also in written response. So let me now call Nuke to give a final word and close the event. Nuke?
Oh, hi, hello. Oh, sorry. Okay. Hi, hello. I just want to announce today that in response to COVID-19, we have built a new website that you can find all the materials from the previous global seminars, and you can, and also other research that we have been doing on the subject. The website is in the www.covid19indonesia.net. I've written it down in the chat. So yes, looking forward to see. And for next week, we will have Dr. Amalinda Safirani from Universitas Gadjah Mada, who will be talking about civil participation, and also Dr. Rus'an Nasruddin from Universitas Indonesia. Okay, thank you, Acho.
Thank you, Nuke. And let us thank our speakers, Mbak Ines Atmosukarto, Anindita Gabriella, and Aditya Wardhana, Edo. Thank you so much for sharing your knowledge with us, and thanks for all the participants. Thank you for asking questions and also participating in this webinar. So looking forward to see you again next week. Thank you so much.